Welcome back to the Deep Dive. Usually we start these sessions with a bit of a warm-up, maybe a fun fact to get things going. But today, the mood here is a little different.
It is. It's heavier.
Definitely heavier. The stack of books is taller, the coffee is stronger.
We aren't here for casual edutainment today. We are here for business.
Right.
Specifically, the business of passing one of the most grueling examinations in medicine, the MD Anesthesiology Finals.
Exactly. And just to set the scene for you listening, I am no longer just the host. For this session, I'm the candidate. I'm the stressed-out postgraduate student cramming for the Gujarat University exams.
And this could be for the DNB, the FRCA, any of them, really.
Or any of them. And you.
I am your senior faculty examiner. I'm the one on the other side of the Viva table. I have the marking sheet, and I am deciding if you're safe enough to be in an operating theater alone.
That is a genuinely terrifying prospect. So the topic today on the syllabus is respiratory movements in anesthesia. And I have to be honest, when I first saw this, my instinct was to skip it.
It just sounds so basic. You know, patient breathes in, chest goes out. Why are we doing a whole deep dive on this?
And that, right there, is exactly why candidates fail this station. More importantly, it's why patients can get hurt.
Okay.
If you look at our sources, we've got Miller, Morgan, and McHale, Wiley, the Capnography text. They all say the same thing. Observation is the absolute bedrock of patient safety.
Not the monitors.
Not the monitors. The monitors come second. Miller states it plainly that intraoperative respiratory monitoring is a fundamental part of the ASA standards. But what did we have before all the machines that go ping?
We had our eyes. And our hands, I suppose.
We had clinical observation. And Wiley makes a really profound point about the chest wall. It has two functions. The first one is obvious, the ventilatory one, moving air. But what's the second?
The supportive function.
The supportive function, exactly. The chest wall has to maintain the shape of the lungs against their own elastic recoil. It's a structural support.
Of a scaffold, a dynamic scaffold. And when we give anesthesia, we just demolish that scaffold. Wiley says, and this is a line you should burn into your memory for the exam, the slightest obstruction to breathing results in visible changes, often before monitors pick it up. The slightest obstruction. Okay, so the mission today is to train my eyes to be faster than the pulse oximeter. That's it. Your eyes need to be the first line monitor. So we're going to do this systematically. The way you'd structure a 20-mark answer or a Viva. We'll start with normal mechanics.
Right.
Then the effects of anesthesia, which is where the exam goal is. Then we'll hit abnormal movements and tie it all together with monitoring and exam traps. Are you ready?
I am. Let's start with part B then. Normal respiratory movements. So if the examiner asks me to describe the mechanics of normal breathing, I'm guessing the diaphragm moves won't be enough.
You'll get you a very long, very uncomfortable silence. You need detail. You need numbers. Start with the prime mover, the diaphragm. Mechanically, what happens when it contracts?
Okay, so anatomically, the diaphragm is a dome-shaped muscle. When the muscle fibers shorten, they pull the central tendon downwards.
Right.
And because the costal attachments are fixed to the lower ribs, this descent of the central tendon effectively lowers the floor of the thoracic cavity.
Good. Now, quantify it. Anesthesia is a science of numbers. How far does it descend?
Morgan and McHale gives the numbers for this. During quiet breathing, it's about 1.5 centimeters.
Yeah.
But during forced or deep breathing, that excursion can increase massively, up to about 6 or 7 centimeters.
Correct. And that movement, what does it translate to in terms of volume change in the chest? What's its contribution?
It's the vast majority.
Yeah.
The diaphragmatic movement accounts for about 75% of the change in chest volume during a normal inspiration.
75%. Think about that number. It's huge. It means 3/4 of your patient's ventilation is dependent on that single muscle, that one piston.
Which is why things like a phrenic nerve injury or a really high spinal are so dangerous.
Absolutely critical to understand. So if that's 75%, what about the other 25? The rib cage.
The rib cage handles the rest. And this is primarily the action of the external intercostal muscles. The ribs, they articulate with the vertebrae at the back, and they slope downwards and forwards.
That downward slope, that geometry is the key. Why?
Because when the external intercostals contract, they pull the ribs up. And because of that angle, they don't just move up, they swing outwards.
Which gives us those classic analogies.
The pump handle and the bucket handle movement.
Explain them.
The pump handle is for the upper ribs. They move the sternum forwards, which increases the anterior-posterior, or AP, diameter of the chest. The bucket handle is more for the lower ribs. As they swing up, they also move laterally, outwards, which increases the transverse diameter, like lifting the handle of a ducat.
Excellent. Now, I want to bring it back to that supportive function from Wiley. In a conscious, awake person like you right now, your intercostal muscles have a resting tone. They're stiff. Why is that stiffness so important for the diaphragm's job?
It's because the diaphragm is creating a vacuum. It's a piston. If the chest wall didn't have that tone, if it was floppy like a plastic bag, the negative pressure would just suck the chest wall inwards.
Instead of pulling air down the trachea.
Right. The tone keeps the cylinder rigid, so the piston actually works on the lungs inside, not on the wall of the cylinder itself.
Perfect. That concept, chest wall impedance, chest wall stability, that is the single thread that ties this entire topic together, because the first thing anesthesia does is cut that thread.
It destroys the stability.
It makes the cylinder floppy.
Yeah.
But before we get to the drugs, let's talk about position. Morgan really emphasizes this.
Gravity, of course. When we're standing or sitting up, gravity pulls all the abdominal contents down. The liver, the spleen, the stomach, they're all pulled away from the diaphragm.
Unloading it.
Exactly.
Yeah.
But when we lie, the patient's supine.
The opposite. Everything slides back up. It's like a column of semi-solid fluid pushing right up against the underside of the diaphragm.
And what's the physiological cost of that? What's the number the examiner wants to hear?
The number is the reduction in functional residual capacity, the FRC.
And Morgan states that just lying supine, compared to standing, reduces the FRC by 0.8 to 1 full liter.
A full liter,
Yeah.
just by lying down. That's a huge loss of your oxygen reserve before you've done anything. Now, in that supine position, does the diaphragm move evenly?
No, and this is a really interesting detail. Morgan points out that the weight of the abdomen pushes mostly on the dependent part of the diaphragm, the dorsal or back part. So that dorsal part actually moves more cephalad. It's pushed further up into the chest. And it has a greater excursion during inspiration to overcome that weight. The front part stays relatively still.
Which is correct. In a spontaneously breathing conscious person, ventilation actually becomes more efficient in those dependent zones. Now, make it worse. Put them in Trendelenburg. Head down.
Now it's a disaster for the FRC. The abdominal organs push even harder on the diaphragm.
And that's not all.
No, you also get an increase in intrathoracic blood volume. Blood drains from the legs and pools in the great vessels in the chest, which makes the lungs less compliant. FRC plummets even further.
And if we sit them up?
Sitting up is protective. It preserves the FRC. So inducing a patient in a sitting position has a very minimal effect on their FRC compared to their standing baseline.
Which is precisely why we pre-oxygenate obese patients or pregnant patients sitting up. We're using gravity to our advantage to unload that diaphragm.
Okay. So we've set the baseline, normal mechanics, effects of position. Now let's get into the exam goal, Part C, the effective anesthesia.
This is where you score the big mark. So let's talk about that term you mentioned, the cephalad shift. Let's set the scene. You've given a dose of propofol. The patient is losing consciousness, but they are still breathing on their own. You haven't paralyzed them yet. What is happening to their respiratory mechanics in those first few moments?
Miller describes this really well. The induction of anesthesia causes a generalized loss of muscle tone everywhere.
The flaccidity.
Yeah. And that includes the inspiratory muscles that were actively holding the ribs up and out and keeping the diaphragm tensioned. As they relax, the diaphragm shifts superiorly, cephalad, up into the chest cavity.
It creates a smaller box, smaller container, and the FRC.
It drops again. Morgan quantifies this. Induction reduces the FRC by an additional 0.4 to 0.5 liters.
Okay, so let's do the arithmetic for the examiner. Put it all together.
So we lost, say, about 1 liter just moving from standing to supine. Then we lose another ½ liter from the induction agent. So we're down 1.5 liters of our oxygen reserve before the surgery is even started.
Exactly right. And in an elderly patient or someone with lung disease, that reduction is often enough to push their FRC below their closing capacity.
Which means you get small airway collapse and atelectasis right from the start.
You're forming shunt before you've even made an incision. Now, here is an absolutely critical concept, a separation of powers, if you will. Does an anesthetic like propofol or sevoflurane depress the diaphragm and the ribcage muscles equally?
No. This is key. Both Miller and Wiley highlight this. There's a separation of function. The diaphragm is relatively preserved. It's a tough, fatigue-resistant muscle. It keeps on contracting, even at quite deep planes of anesthesia. But the intercostal muscles are very, very sensitive. They get depressed much earlier. They become hypotonic, floppy,
And this is the setup for the crime. This is the whole story. You have a working pump, the diaphragm, still generating that negative intrathoracic pressure.
Right.
But you have a broken floppy cage, the intercostals, that has lost its supportive tone.
And that imbalance is what sets the stage for paradoxical breathing, which I know we're getting to.
We are. But first, let's just quickly touch on the chemical drive. How do anesthetics affect the brain's desire to breathe? Miller talks about this.
The inhaled agents, the volatiles like sevoflurane, they cause a very specific pattern. It's tachypnea, so a fast rate, but with a reduced tidal volume.
Rapid, shallow breathing. Why do they breathe fast?
It's a sort of primitive reflex to try and maintain minute ventilation. But the important part is that their response to carbon dioxide is blunted.
Meaning?
The CO2 response curve flattens. They'll tolerate a much higher level of CO2 in their blood before their respiratory center is stimulated to increase ventilation.
Right. And what about the opioids? Fentanyl, morphine?
It's the opposite pattern, really. Opioids act on the new receptors in the brainstem, and they just slow everything down. They cause bradypnea, a slow respiratory rate.
But the tidal volume?
Initially, they might still take a big breath, a large tidal volume, but the rate just drops and drops.
It's the classic patient forgets to breathe syndrome. Okay, now let's talk muscle relaxants. A full paralyzing dose is obvious. It causes apnea. But what about that specific term the capnography source mentions that examiners love to ask about, the Curare effect?
The Curare effect or the Curare cleft. You see this during recovery from the neuromuscular blockade.
Describe it. What does it look like clinically, and what do you see on the monitor?
Clinically, the patient might be making these little jerky, spontaneous respiratory efforts, just small twitches. On the capnograph, you see a cleft or a notch cut out of the alveolar plateau, phase 3.
And what is the mechanism? Why does that notch appear?
It happens because the diaphragm, being the powerhouse it is, recovers from the blockade before the other muscles. So the ventilator is in its expiratory pause.
Right, holding the pressure.
And the diaphragm suddenly tries to contract. This little inspiratory effort sucks a tiny bit of fresh, CO2-free gas from the circuit back past the sampling line.
And that causes a momentary dip in the measured CO2.
Exactly. It creates the cleft. It's a sign of patient ventilator asynchrony. It tells you the patient is waking up, the block is wearing off, or your dose was inadequate.
Very good. Before we jump into the abnormal movements, I want to properly close the loop on regional anesthesia. We mentioned high spinals.
Right.
So you have a spinal block that's gone up to T4, let's say, the nipple line. You have effectively paralyzed all the intercostal muscles.
But the diaphragm is innervated by C3, 4, 5. C3, 4, 5 keeps the diaphragm alive. So ventilation should technically be adequate, right?
Physiologically, at rest, yes. The diaphragm can handle the full workload. But what does the patient do?
The patient panics.
Yeah.
They'll often say, "Doctor, I can't breathe. I'm suffocating."
And their SpO2 is 100%. Why the panic?
It's about proprioception. We don't just know we're breathing because air moves. We feel it through the expansion of our chest wall. There are stretch receptors in those intercostal muscles sending signals to the brain saying, yep, we're breathing.
So if you paralyze those muscles,
the chest wall doesn't expand outwards in the same way. The brain gets no feedback signal. And it interprets that lack of signal as apnea, as suffocation.
Even if gas exchange is perfect.
It's a sensory failure, not a respiratory failure.
That is a crucial clinical pearl. Your job is to reassure them based on the objective data from the monitor, not their subjective feeling.
Okay, that's a great point. Let's move to the real meat of the exam. Part D, abnormal respiratory movements, the heart of the observation station. If I'm in a Ziva and the examiner says, classify abnormal respiratory movements for me, where do I start?
You start with the most dramatic and the most dangerous one, paradoxical respiration.
Paradoxical, meaning contrary to what you'd expect.
Describe it visually. Paint a picture for me.
It's the chest in, belly out movement, or sometimes called a rocking boat or seesaw leading. On inspiration, the abdomen rises normally, or even exaggerates its rise, but the chest wall actually collapses inwards.
And on expiration,
the abdomen falls and the chest may recoil back outwards. It's this bizarre, inefficient rocking motion.
Correct. Now explain the mechanism. Why does the chest go in?
It all goes back to that imbalance we established earlier. The diaphragm is working, it contracts, it descends, and it pushes the abdominal contents out. That's the belly out.
Right.
That contraction creates a significant negative pressure inside the thorax. But because the intercostals are weak or paralyzed, the supportive tone of the chest wall is gone. The cage is floppy.
And it can't resist the vacuum.
It can't. So the negative pressure just sucks the flaccid chest wall inwards.
Very good. Now, Wiley links this sign to two primary causes in the anesthetized patient. What are they?
Deep anesthesia, which causes that muscle flaccidity, and airway obstruction.
Let's focus on obstruction because it's the more urgent problem. What was that quote from Wiley?
It says, the slightest obstruction to breathing results in greatly exaggerated paradoxical ventilation.
Greatly exaggerated. That's the key. If you're holding a mask on a patient and their tum falls back, even a little, the resistance to airflow shoots up.
So the diaphragm has to pull much harder to get any air in.
Exactly. The vacuum it generates becomes much stronger, and the inward collapse of the chest becomes much more violent.
Yeah, so as a clinician, if I see that rocking chest, my first thought shouldn't be, oh, the patient is deep. It has to be.
The airway is blocked. Always. Airway first. If you see that seesaw motion, you assume the airway is compromised until you prove otherwise.
So I'd perform a jaw thrust, maybe insert an oral airway.
Yes. And if the rocking stops and the chest starts to rise and sink with the abdomen, you've just diagnosed and treated upper airway obstruction in seconds with your hands.
It's interesting because this was a classic sign of depth in Guedel's stages of ether anesthesia.
It was. In stage 3, particularly planes 3 and 4, intercostal paralysis was the defining sign. They didn't have monitors, so they would literally titrate the ether until the intercostals stopped moving, but the diaphragm kept going.
A fine line to walk.
An incredibly fine line before total apnea. Now, let's talk about the use of accessory muscles. You see a patient starting to use their sternocleidomastoids, the SCMs, and their scalene muscles.
The big ropey muscles in the neck.
You see them popping out with every breath. What does that tell you about the physics of that patient's breathing?
It tells me their work of breathing, their WOB, is critically elevated.
Explain why.
Because normal, quiet breathing only requires the diaphragm for inspiration, and exhalation is passive. If you need to recruit your neck muscles, which lift the entire clavicle and top of the rib cage,
You're desperate.
you're desperate. You're generating enormous negative pressures to overcome either a massive resistance, like an obstruction, or very low compliance, like an ARDS or pulmonary edema, stiff lungs.
Morgan refers to this as air hunger.
We see this all the time in the PACU, the recovery room. A patient's been extubated, but they might have some residual neuromuscular blockade. They're doing that fish-mounting gasp, and you can see the trachea being pulled down, the tracheal tug, and those SCMs are firing like crazy.
And that is a sign of impending respiratory failure. They cannot sustain that level of work for long. It's a clear signal for immediate intervention.
Like giving more reversal agent, applying some positive pressure, or, in the worst case, reintubating.
Correct. Now, Section 10 in our outline mentions retractions and asymmetrical movements. Retractions, suprasternal, subcostal, they're just more signs of that same pathology, right?
High negative pressure pulling in the soft tissues where there's no bone.
Exactly. But let's talk about asymmetry. You're in an exam. It's a short case. You're asked to inspect the patient's chest. You notice that one side is moving with ventilation, but the other side isn't. Give me the top anesthetic differential diagnoses.
Number 1, intraoperatively, has to be an endobronchial intubation. The tube has gone too deep.
And it's usually gone into which bronchus?
The right main bronchus.
Why the right?
It's just anatomy. The angle of the right main bronchus from the trachea is much shallower, about 25 degrees, compared to the left, which is more like 45 degrees. The tube just follows the path of least resistance.
It's a straight shot down the right side, so if the tube is in the right bronchus, you'll see the right chest rise and fall.
And the left chest will be still.
And here's the exam trap. The examiner asks, how will you confirm your suspicion? And if you say,
I will auscultate the chest.
you don't fail, but you lose a lot of marks.
Why?
Because breath sounds are liars. They are notoriously misleading, especially in the operating theater. Sound transmits very well through the solid and fluid media of the thorax. You can easily hear what sounds like air entry on the left side, even when the left lung is completely collapsed.
So direct observation, looking at the chest movement, is actually superior to listening.
In this specific case, absolutely, and it's the gold standard in thoracic anesthesia. When you place a double lumen tube to isolate one lung for surgery, the way you check it clinically, before you use a bronchoscope, is you clamp one lumen and you watch the chest.
So if you clamp the bronchial lumen going to the left lung, the left chest had better stop moving.
It must be completely still. If it's still heaving or rising, your tube is in the wrong place and your isolation has failed. The surgeon will not be happy.
What about a pneumothorax? That can also cause asymmetrical movement.
It can, but it looks different. In a tension pneumothorax, the affected side is often hyperexpanded and immobile. The ribs are pushed out and fixed in place. That's a very different picture from a simple collapsed lung or atelectasis, where the affected side might look sunken and immobile.
Got it. Okay, let's move on. Part E, abnormal breathing patterns. This is where the outline lists the textbook classics. Cheyne-Stokes, Biolt's breathing, Kussmaul respiration. I have to admit, these always feel more like internal medicine viva questions.
They do, but you need to be able to translate them for the anesthetic context.
Yeah.
We rarely see a perfect classical Cheyne-Stokes pattern, that crescendo-decrescendo breathing with periods of apnea, unless the patient has, say, end-stage heart failure or severe uremia.
But we see drug-induced versions of these patterns.
Exactly. We've already covered the most common ones: tachypnea from volatile agents, bradypnea from opioids. But let's focus on the patterns that you're going to be diagnosing with your monitor, specifically the capnograph. This is section 12.
The shark fin.
The shark fin. This is the capnographic equivalent of seeing obstruction. So you look at the patient, and you see a struggling paradoxical chest movement. Then you look at the monitor. What does the waveform look like?
Instead of a nice crisp rectangle, the upstroke phase 2 is sloped. It rises slowly.
Why?
Because exhalation is obstructed. The gas can't rush out of the alveoli, it has to trickle out through narrowed airways. So the sensor at the end of the tube sees a slow, gradual rise in CO2 concentration.
In the plateau.
Phase 3, the alveolar plateau, also slopes upwards because different parts of the lung are emptying at different rates. The slow alveoli empty last, pushing the CO2 value up right until the end of the breath. It looks just like a shark's dorsal fin.
Perfect. So clinical sign, rocking chest. Monitor sign, shark fin waveform. Diagnosis.
Bronchospasm, like in an asthmatic or some kind of mechanical obstruction like a kinked endotracheal tube.
Excellent. What about rebreathing? What does that look like?
On the capnograph, rebreathing is when the baseline, phase 1, doesn't return to zero, it's elevated.
Which tells you what?
It tells you the patient is inhaling carbon dioxide on the next breath, which means there's a failure in the breathing circuit. Either the soda lime is exhausted and can't absorb CO2, or one of the unidirectional valves is stuck.
And how might the patient's breathing pattern change if they're not paralyzed?
Their own respiratory drive will kick in to fight it. They'll start breathing deeper and faster hyperpnea, trying to blow off that extra CO2 load and correct the acidosis.
Good. Okay, let's move to part F. This is the clinical correlation. I want you to talk me through a nightmare scenario. The one every anesthetist dreads, especially with trainees. Laryngospasm.
The silent chest.
Why do we call it silent?
Because sound requires airflow. If you hear a noise like stridor, that high-pitched crowing sound on inspiration, it's actually a partially good sign. It means there's still a small gap and some air is moving through it.
It's a partial obstruction.
Right, but in a complete laryngospasm.
The vocal cords have slammed shut. They are fully adducted. It's a watertight seal. No air in, no air out. And if there is zero flow, there is zero sound.
So the room goes quiet.
Deadly quiet. But the patient is the opposite of quiet. The patient is making a maximal panicked respiratory effort. Their brainstem is screaming for oxygen. The diaphragm is contracting with all its might.
So what do you see visually?
You see a violent paradoxical movement, a huge tracheal tug where the whole larynx gets pulled down towards the chest with each effort. The sternum sucks in, the belly heaves out.
But the reservoir bag on the machine isn't moving at all.
And a capnograph trace is a flat line. Zero.
And this is where the novice makes a critical error. They look at that flatline capnograph and they think, apnea. The patient has stopped breathing.
Whereas the experienced clinician looks at the chest, sees that violent effort, and knows this isn't apnea, this is a total obstruction. The patient is fighting for their life.
And recognizing that difference, the mismatch between effort and flow, is what prevents a catastrophe.
It is the difference between a safe outcome and developing negative pressure pulmonary edema, NPPE.
Which happens because the patient is generating such a powerful vacuum inside their chest against that closed glottis.
Exactly. They can generate negative pressures of -50, even -100 centimeters of water. It's enough to physically pull fluid out of the pulmonary capillaries and into the alveoli.
How do we treat it?
Well, you prevent it in the first place. But if it happens, 100% oxygen, positive pressure on the bag, a specific jaw thrust called Larson's maneuver, which applies painful pressure at the laryngospasm notch just behind the earlobe.
And if that doesn't work?
A small dose of propofol to deepen the anesthesia and relax the spasm. And if that fails, the definitive treatment is a small dose of succinylcholine to paralyze the laryngeal muscles and break the spasm so you can ventilate.
Okay, let's pivot to the ICU for a moment. Section 15 mentions cardiac oscillations. I've seen this on the monitor, but never fully understood its significance.
Ah, the heartbeat of the lung. This is a very subtle but very elegant clinical sign.
Describe it for me.
So you have a patient who is fully apneic on the ventilator. Maybe they're deeply paralyzed. Or you're performing an apnea test as part of a brain death examination. There is zero gas flow. The chest is completely still.
Okay.
But if you look very closely at the capnograph waveform, right at the end of the expiratory phase, you'll see tiny rhythmic ripples or undulations in the trace.
And those ripples are in time with the ECG, with the heart rate.
Perfectly in time. Think about it. The heart is sitting right in the middle of the chest, physically touching the lungs. Every time the ventricles contract, the heart physically beats against the surrounding lung tissue.
And that little thump displaces a tiny puff of gas.
A tiny volume.
Yeah.
Maybe 2 or 3 milliliters. And that puff of gas is pushed up the trachea, past the sampling sensor.
But only if the airway is open.
Ah, you've got it. That's the key. It's a connectivity test.
So it's proof of a patent airway.
It's definitive proof that there is an uninterrupted column of gas from the alveoli all the way to your sensor. If the endotracheal tube were kinked or blocked with a mucus plug, or if the patient's glottis were closed, you would not see them.
So seeing those ripples means the airway is open and connected. That's a fantastic pearl.
It is.
We're in the home stretch now. Part G, exam integration. I need to be able to package all this information into a format that's going to get me through the exam.
Yeah.
Section 16 suggests using comparison tables.
Examiners love tables. It shows you can organize complex information clearly and concisely. So if I asked you to create a table comparing a normal spontaneously breathing chest versus an anesthetized spontaneously breathing chest, how would you structure it?
Okay, I'd have 3 columns. The feature, the normal state, and the anesthetized state.
Okay, I'll give you the rows.
Okay, row 1, ribcage movement in the normal column. Expands up and out, the pump and bucket handle, in the anesthetized column. Depressed, immobile, or even paradoxical, moving inwards.
Good. Next.
Row 2, diaphragm position, normal. It's at its normal resting position and descends about 1.5 centimeters. Anesthetized, it's shifted cephalad, so it starts higher up in the chest. Its excursion might be preserved, but from a higher starting point.
Excellent.
Row 3, FRC, normal, baseline, anesthetized, significantly reduced due to both the supine position and the induction agent.
And one more key one.
Row 4, muscle tone, normal, good intercostal tone, providing that's supportive function. Anesthetized, tone is lost, leading to a floppy, unstable chest wall.
That is a distinction level table. Perfect.
Mm-hmm.
What about another common Viva question, comparing central apnea and obstructive apnea?
This one is all about effort. So row 1, respiratory effort for central apnea, absent. The brain simply isn't sending the signal to breathe. For obstructive apnea, present and usually maximal, the brain is screaming for air. Row 2, chest movement, central. The chest is completely still. Obstructive.
Yeah.
Paradoxical, rocking, seesaw movements with retractions.
And the final common factor.
Row 3, gas flow. For both central and obstructive, gas flow is 0. No air is moving.
Exactly. The final outcome is the same, no ventilation, but the clinical picture you observe at the bedside is the complete opposite.
Okay, section 17 lists common exam questions and Viva traps. We already covered the look versus listen trap and the importance of observation over auscultation for endobronchial intubation.
You did. And you survived. Just remember the core reason, latency. Monitors have a lag time. Your eyes are real time.
Okay, here's another trap from the outline. The paradox trap. The examiner says, candidate, the patient is breathing paradoxically. Is the neuromuscular blockade working effectively?
A classic trap. Walk me through the correct, safe logic.
Okay. If the patient is breathing at all, even paradoxically, then the diaphragm must be contracting. It's the engine of the breath.
And if the neuromuscular blockade were working fully and effectively?
The diaphragm would be paralyzed along with everything else. The patient would be completely apneic and still.
So what is your answer to the examiner?
The answer is, no sir or ma'am, the blockade is inadequate or it is wearing off. Paradoxical breathing is a sign of an imbalanced block, not a total block. It means the diaphragm is recovering, but the weaker intercostals are still paralyzed.
Excellent. Never let an examiner trick you into thinking it's a sign of a good block. It's a sign of a partial and therefore potentially dangerous block.
One more trap here, the capnography one. The examiner asks, candidate, is it possible to see a CO2 waveform if you have intubated the esophagus?
And the knee-jerk incorrect answer from a panic trainee is no.
But the correct answer is, yes, it is possible, but only transiently.
And why is that?
It's because during bag mask ventilation before intubation, it's very common to insufflate some gas into the stomach, and that gas will contain CO2 from previous exhalations.
Or if the patient had a fizzy drink before their fasting period started.
Right, so when you ventilate the stomach, you can get a few small diminishing waveforms as you wash out that trapped CO2.
So how do you use the capnograph to confirm tracheal placement?
You must see a sustained trace of consistent height and shape for at least 6 or 7 consecutive breaths. If the waveform is present but fades away to nothing, you are in the esophagus. Take it out.
That is the safe answer. Perfect.
Section 18 talks about diagrams. If I'm in the theory exam and I have a pen and paper, what should I draw to get extra marks?
Draw the cylinder concept we discussed for paradoxical breathing. It shows you understand the mechanism.
So 2 pictures.
Yes. Draw 2 simple diagrams. For normal breathing, draw a cylinder for the chest and label arrows pointing out from the sides. Draw the floor of the cylinder, the diaphragm, with an arrow pointing down. For paradoxical breathing, draw the chest cylinder with arrows pointing inwards. Draw the diaphragm with an arrow pointing down, and you label it clearly. Mechanism of paradoxical respiration. Diaphragmatic contraction with loss of chest wall stability.
And for the capnography waveforms.
You must be able to draw the shark fin, label the prolonged upstroke, and draw the Curare cleft, a sharp little V-shaped notch in the alveolar plateau. These simple drawings communicate a huge amount of understanding.
Visual score marks.
Visuals demonstrate understanding beyond just memorizing text.
Okay, finally, section 19, the summary. If I get a 20-mark long answer question or I need to structure a full Viva station on this topic, what is the framework?
You need a clear roadmap so you don't get lost or start rambling. Here is your distinction level 15 to 20 mark framework.
Okay, I'm ready.
1. Introduction. Start by stating the importance. Clinical observation of respiratory movements is a fundamental component of ASA monitoring standards. Mention the 2 key functions of the chest wall, ventilatory and supportive.
Okay, intro done.
2. Normal anatomy and physiology. Briefly describe the roles of the diaphragm, highlighting its 75% contribution versus the intercostals. Crucially, you must mention the physiological reduction in FRC when a patient moves from standing to supine. 3. The effects of anesthesia. This is the core of your answer. Describe the cephalad shift of the diaphragm, then explain the critical dissociation. The diaphragm's function is relatively preserved, while the intercostal muscles are significantly depressed. This is the setup for all subsequent problems.
Right.
4. Abnormal movements and patterns. Define paradoxical respiration. Use that cylinder diagram you practiced. Explain its 2 main causes: deep anesthesia and airway obstruction. Mention specific critical events like the silent chest of complete laryngospasm.
And finally,
Hive, monitoring and correlation. Tie the visual signs to the monitor. Explain how paradoxical breathing correlates with a shark fin capnogram and bronchospasm, and how recovering diaphragmatic efforts cause Curare clefts. And 6, conclusion. End with a powerful, safety-oriented statement, something like, ultimately, the anesthetist's clinical eye is the primary real-time monitor of respiratory function. Electronic monitors provide valuable data, but they serve to confirm and quantify what is first observed.
it feels incredibly thorough. It covers the why, the how, and the so what.
That is what the examiner is looking for. They want to know you're not just a technician who can read numbers, but a clinician who can interpret a physical picture.
Before we wrap up, the outline has one last point. A final provocative thought.
Yes. We spent this entire session talking about observing the chest wall, looking at waveforms, measuring pressures and flows, but are we actually measuring the most important thing?
What do you mean by that?
The whole point of respiration isn't to move the chest. The point is to get oxygen molecules into the mitochondria so they can produce ATP.
Cellular respiration.
Precisely. You can have a patient with a perfectly moving chest, a pulse oximeter reading of 100%, a normal capnograph, and a great blood pressure. But if that patient has cyanide poisoning or raging septic shock, their mitochondria can't use the oxygen you're delivering.
So the cells are suffocating even with perfect ventilation.
The cells are dying while the chest is moving beautifully. We are experts at monitoring the transport system, the trucks on the highway, but we have very few ways to know if the factory at the end of the road is actually running.
So the future of monitoring might move beyond looking at the chest to looking directly at the cell.
Perhaps. The future of our specialty might be moving from monitoring respiratory movements to monitoring cellular oxygenation directly. That's the next frontier.
From watching a heaving chest to watching a single mitochondrion. That is a deep dive for another day.
It's what makes our field so fascinating. It spans from basic physics and mechanics all the way down to subcellular biology.
Well, thank you. This has been incredibly intense. I feel like I've been through a 2-hour Viva, but I also feel much, much more prepared.
Good. That was the goal. Take that preparation, walk into that exam hall with confidence, and for goodness sake, remember to look at the patient first.
To everyone listening, whether you're sitting for your exams or you just want to be a safer clinician at the bedside, keep studying, keep practicing, and trust your eyes before you trust the machine.
See you in the operating theater.
Thanks for listening to The Deep Dive.